You hear it overhead. Stroke code, ED room 2. You know that feeling, right? The clock starts ticking, you've got the protocol down cold, but what if I told you that protocol is already out of date? It's 2026 and the game has just changed.
So, first up, we have to ask, has alteplase, the thrombolytic we've all relied on for decades, finally been challenged? There's a new-ish player that's simpler, faster, and just as good, and it's now officially a frontline option. And then there's that clinical situation that drives us all crazy, the wake-up stroke. The patient with a clear deficit, but a completely unknown time of onset. For so long, our hands were tied. Well, it turns out we might just be able to pry that treatment window back open. Now, everything we're about to cover isn't just theory. It comes straight from the top. The American Heart Association and American Stroke Association's brand new 2026 guideline for the early management of patients with acute ischemic stroke. It was just published in their journal, Stroke. And of course, the links to the bibliography are in the description below.
So let's get into it. You shouldn't think of this as just another long document. This is our new clinical playbook. It's the new standard of care, and it's designed to make us all faster and more effective. First, let's talk about the big one, a huge practice-changing update. A new thrombolytic option has officially entered the arena, and it's got a top-tier recommendation.
Okay, look at this comparison. It really says it all. For years, alteplase, or TPA, has been our reliable workhorse. It's like a shotgun, a bolus followed by a 1-hour infusion. It absolutely works. But tenecteplase, TNK, is more like a sniper rifle. It's a single IV bolus, 0.25 milligrams per kilogram, capped at 25 milligrams. One shot and you're done. This is a game changer for workflow. It simplifies everything, reduces the potential for error, and helps shave those precious minutes off our door-to-needle times. And the key takeaway here is that the guidelines now say TNK is a recommended option, right on par with alteplase.
All right, on to the next major update. This one is all about time. We're now looking at an expanded window for IV thrombolysis, which is huge for those patients who, in the past, we just couldn't treat.
So to understand how we can treat later, we need to talk about the ischemic penumbra. I want you to picture the brain during a stroke. You've got the core of the infarct. That tissue is gone. But surrounding it, there's this area of brain tissue that's, well, it's flickering. The neurons are stunned, they're starving for oxygen, but they're not dead yet. That's the penumbra. That's the brain we can still save. It's literally a race to restore blood flow before that light goes out for good.
And this is how we do it. Here's the new protocol. For a patient who wakes up with symptoms or presents between 4.5 and 9 hours after they were last seen well, we now have a plan. We get advanced imaging, like a CT perfusion scan, and we're hunting for that penumbra. We're looking for a mismatch, a small core of dead tissue, and a much larger area of salvageable brain. If we see it, the guidelines now say, give the thrombolytic. It's a massive shift. We're no longer just treating the clock, we are treating the brain's physiology.
Now, it's really important to make a distinction here. This new, wider window is for IV thrombolysis. It does not change our criteria for endovascular thrombectomy, or EVT. For large vessel occlusion, our fundamental tools, like the aspect score on a non-contrast CT, are still absolutely critical for deciding who gets a thrombectomy. Think of this new IVT window as another tool in our kit, not a replacement for our existing EVT protocols.
So let's boil all this down. What does this mean for you today on your very next shift? I've got 3 high-yield, actionable takeaways for you. First thing, tenecteplase is go. The guidelines give it a full endorsement. You can use tenecteplase at 0.25 milligrams per kilogram as a first-line agent, right alongside alteplase. It's time to start talking with your pharmacy and your stroke committee about making this switch. It just makes things easier. Second, the window is wider. For those specific patients, the wake-up strokes, the 4.5 to 9 hour presentations, you need to get that advanced imaging. If you see a good amount of salvageable penumbra, you are now fully supported by the guidelines to give IV thrombolysis.
And third, and this one is so important, thrombolysis first. For any patient who comes in and is clearly within that standard 4.5 hour window, you do not delay giving lytics to get advanced imaging. The time is brain mantra is still king. Get that thrombolytic in fast. The extended window protocol is only for the extended window patient.
All right, let's wrap this up with a simple way you can remember these key updates, and maybe more importantly, how you can share this information with your colleagues.
Here you go. This is your conversation starter. When you're talking about the new guidelines, just remember this phrase, Stroke 2026. Think TNK, time and teamwork. It's simple, right? TNK for tenecteplase, our new single bolus option. Time for that expanded treatment window. And teamwork, because none of this happens without a coordinated effort from everyone, EMS, the ED, neurology, radiology, and pharmacy.
So, the bottom line is this. The 2026 guidelines have given us a fantastic new thrombolytic option in tenecteplase. They've also widened the treatment window for certain patients by using imaging to find salvageable brain. And through it all, they've doubled down on the absolute urgency of treating everyone else as fast as humanly possible.
Look, the next stroke code is never more than a few minutes away. Every second that ticks by, more brain cells are lost. So I want you to take one of these updates, TNK, the wider window, the thrombolysis first rule, and share it with a colleague on your very next shift. That one conversation might just change a patient's entire life.
Disclaimer and bibliography in the description.